at the height of the COVID across the globe, people were dying of cerebrospinal meningitis in the northern and upper regions of Ghana than COVID-19. Malaria continued to kill people in Ghana than COVID-19. Indeed, NCDs, non-communicable diseases, are increasing in Ghana and causing a lot of death than COVID-19. We are always interested in what will give the West and the so-called puppet masters money to do what they do.
So the figures are exaggerated.
That's the point I'm trying to advance.
Because a lot of the people...
That's the point I'm trying to advance. Because you see, the question about medical errors will come up in the foreseeable future. We have refused to pay attention to Africa's social capital and Ghana's social capital. For example, we have suffered from malaria, which has been endemic in the region of sub-Saharan Africa and Ghana for that matter. And malaria remains the number one killer disease in our part of the world and continues to decimate lives beyond COVID-19.
Hello, everybody. My name's Toby Green, and I'm a member of the Scientific Advisory Board of Collateral Global. And welcome to Unrestricted, the Collateral Global podcast. And it's my great pleasure to welcome an old friend of mine, Dr. Samuel Adu-Gyamfi. Samuel, welcome to Unrestricted.
Thanks for having me.
So, Samuel, before we get going, maybe it would be interesting for our listeners and our viewers to find out more about yourself and your area of expertise. So can you tell us a bit about that?
So you've already mentioned my name. Just for emphasis, I'm Samuel Adu-Gyamfi, and I'm a senior lecturer at the moment, the head of department for the Department of History and Political Studies at KNUST, Kwame Nkrumah University of Science and Technology. I also work as the senior editor of Cogent Arts and Humanities Journal for the history section. Indeed, I would rather consider myself as an applied historian, but broadly within the framework of science, so that I'm a social historian of science and medicine. My interests also lie within the domain of health policy, social change, and history education. And so broadly, I'm interested in looking at societal questions, applying ethnographic historical techniques to be able to ask further questions and possibly proffer solutions to current predicaments and what could even befall us in the future. So, whereas typical traditional historians might want to shun from policy, I'm interested in to what extent history would inform policy, among other things. Right.
So, and as you say, you're a historian of science and of medicine. Right. So no doubt that has made you particularly interested over the last 18 months in the response to the COVID-19 pandemic, both in Ghana and in the rest of the world.
Yes, very much. I have shown keen interest at the moment. I have a systematic kind of review paper with colleagues that look at broadly the thrusts of the COVID in the spokes of the world. And my interest is in how same has impacted, if you like, global economies. And for that matter, I ask questions around the puzzlement with respect to Africa and also, for that matter, the Ghanaian case. Just before we came to this discussion, Modern Africa, Journal of History, Politics History, has also accepted our paper on, by June, everyone would have died, historicizing humor during COVID-19. Right. I've also, in the main, also looking at dilemmas between doctors and patients, or health workers and patients during pandemics or epidemics. I've also tried to make a contribution to an upcoming a book project, right, to share some Ghanaian experiences and what Ghanaians really have been through and all that. So for me, from where I sit, I've been very much interested in the discussions. I've also engage the public via a national media like TV3 Network, which I used to feature every Tuesdays and sometimes Thursdays, during the heat of the COVID, I was at the forefront of the discussions in Ghana and raised my own queries, questions, and also shared my predilections, among other things, right?
That's excellent. So, I mean, I'm sure our viewers and listeners will see that you obviously know a lot about the situation with regard to COVID in Ghana and also the policy response to that. So with that knowledge, tell us about the Ghanaian policy response to COVID. What was the Ghanaian policy and how was this received in the country?
Let me be quick to say that the lockdown policy response, especially to COVID, was a hastened one. And for many countries, that would have been the case because the idea was to quickly make sure that with the index case, the first index case around March, it will not spill over to other areas, especially Greater Accra region, which is the capital city of Ghana, and Kumasi, where my university is, which is also one of the biggest cities and also eclectic like Accra is. So the policy, as it were, was quickly to make sure that Ghanaians would not be caught beyond the already exacerbating situation. I mean, we understand the question around health fragility within the African context and for that matter, the Ghanaian context, so that if you want to even have a broader discussion around even the Ebola and other forms of epidemics, always the discussion comes up with, health fragility, economic fragility and all that. And so the government of Ghana, out of desperation and also trying to, if you like, save the situation, quickly looked at the question of lockdown as one of the strategies. But it was on three levels, if you like. The idea was to test, trace, and treat within the broader public health framework so that if they were able to ascertain how many people were infected, then they could, properly help those people to quarantine and more so to be able to hospitalize those who need hospitalization. But largely, it was also because of the fact that clearly the number of ratio, in terms of ratio between physicians and patients, nurses and patients, is broadly wide. I cannot speak specifically to the figures, but in some of my earlier studies, I've alluded to some of these questions. For example, my work concerning nursing in Ghana, except for Florence Nightingale in an African city, I tried to look at some of the questions around dilemmas between the relationship between nurses and patients and all that. So broadly speaking, if you look at distribution in terms of personnel, health personnel, we have limited numbers. Then if you look at...
So this was a very important point, wasn't it? Because there, as you say, there was a sense of desperation when the pandemic began in March 2020. And also a lot of the World Health Organization and various international organizations were pointing to what you're saying, the fragility of health systems in many African countries, and the need, therefore, to prevent the disease from spreading. And so that led to the lockdown policy, which, as you say, was a sort of a hasty response. So those were the reasons, I suppose, why the policy was imposed. But in terms of the restrictions on people's movements and livelihoods, what were then the impacts of that?
We can agree. Broadly, if you look at it, within the broader discussions in the literature and also what really, empirical evidence also, the fact that Greater Accra being the hub of the major economic activities in Ghana, and with the centralization of power and activities in Accra, it meant that the entire country was under lockdown. That's what it meant. Because a majority of the population that would want to perform critical issues or perform critical activities would eventually end up in Accra, i.e. matters relating to passport, matters relating to even employment, matters relating to company sponsorship, to events, activities, search for new jobs and all that leads to Accra. So that the Ghanaian economy, largely agrarian, but administratively is, premised on Accra. If Accra is the centrality of Ghana's development, among other things, then a shutdown of Accra meant that, and contiguous town like Ewutu, Senya East and all that, and also Kaswa, which are contiguous communities and all that, meant that a major sector of Ghana's economy had been shut down. But more so, it also meant that women and children were going to be at the serious, receiving end, especially at the negative side. For example, our women who are quite often the producers of the bread and butter for our homestead would get up early in the morning, sometimes as early as 4 a.m., to crisscross the territories across contiguous villages and communities to go to central Accra, Tudu, and other markets, right? Including even the infamous Abu Blushi and all the other areas, to engage in respective economic activities to provide bread and butter for their household. The informal sector largely supports the Ghanaian economy, and within this period, all these things were shut down. And we saw, in the news, women saying that this cannot be, especially women groups at Kaswa and other areas who would find some subtle means of not, if you like, complying to the lockdown regime or policy. It is also important to also say that Kumasi, which also had some increasing number of infections following up after Accra, also is eclectic. And what it means is that the lockdown also shut down the economic activities, because Kumasi would be at the middle of Ghana, so to speak, forest region, but it's also kind of food basket, because geographically, yes. So that all those who are crisscrossing from the northern and upper regions to Accra would have to go through Kumasi and all that. In fact, even for those, Burkina Faso, which is a landlocked country, which uses the port in Takrade and Accra, will still have to come through Asante region and all that. So geographically, with the lockdown of Kumasi, it also meant that several things were shut down, and largely the informal sector was also shut down. Now, two things happened. The government, by implementing this lockdown policy, was interested in trying to curb the impact of same on the people. For example, the government was interested in supporting those communities that could not feed. The government made attempts to give packaged foods, right, packed lunches and all that, but that was a fiasco. It was not a successful project. Why? Because the lockdown policy in itself required that there will be element of social distance, and people would not be seen to be in close proximity. But around this time, when they tried to distribute packed lunch, people moved en bloc or en masse to cluster around places to get this packed lunch. So it was a breakdown of the COVID policy on its own.
So in fact, what was happening was, on the one hand, you mentioned the informal sector. Many of our listeners may not know, and our viewers may not know, but there are various estimates, but somewhere between 60 and 80% of the Ghanaian population relies on the informal sector. They don't have formal employment. I think that's about the figure, isn't it, more or less?
Right. So
and so if you close down the economy for the informal sector, and move, and also I think the other thing that people may not necessarily appreciate is that movement is fundamental. As you were saying, people have to go to market, they're bringing things to sell, or they're going, and that is how they are making the informal sector work. And so preventing movement is simply taking away the lifeblood of virtually the entire country's economy. Is that a fair summary?
Exactly, it's a fair summary. More so, it's the informal sector includes the artisanal sector that caters those into baking and basketry, other related industries. I mean, the work of the drivers and the commuters themselves. So broadly, caters those who are selling spare parts and all that. So broadly, that market was shut down. And the major hub of the market, you find them in Accra and in Kumasi, because it is in Accra and Kumasi that if you like, the ebullience of Ghana's economy radiates to other sectors of the economy. And so once you shut down the two critical cities, Kumasi and Accra, it means that technically you've shut down the entire country. More so, we must also look at the question of, economic fragility in its sense. For example, we talk about carton foods, right, from the hinterlands. Already, we have impassable areas. Perishable commodities.
It all got wasted.
They go wasted even in normal times. So under such conditions, what it means is that the waste will also increase, and so we have increasing trend in terms of waste, increasing trend in terms of dependency ratio, because those who are breadwinners have also become dependent, and they are now going to depend on the government to support them. And that was not forthcoming in spite of government's effort to, if you like, deal with this particular puzzlement, which had...
it's interesting you talk about the government efforts. And, and I think one of the things, you said that the policy, unfortunately, had the impact of actually being counterproductive to the COVID measures that the government was trying to bring in. Because, of course, if you make people hungry and economically desperate, they will crowd together and try and obtain the food which is being passed out. But I suppose one of the reasons also why these measures to try and support people were so difficult to enforce was because this was a completely unprecedented situation which nobody had planned for. So that must have had an effect as well.
Exactly, because they did not, the country did not plan for that. So the critics of the government, for example, the NDC, National Democratic Congress Party, for example, argues that when the Ebola crisis, right, took place in sister countries in West Africa, what the country did was to step up to support the sister countries. However, it was interested to make sure that our borders were properly safeguarded and to prevent the disease from entering into the country in the first instance. Secondly, they argue, among other things, that the government itself had also breached these, policy that it has set in place. For example, it was also during the heat of a political party rallying and campaigning. The ban for political parties campaign had been lifted. And so political parties began to mobilize themselves and also go out there.
And this was during this was during the election which happened at the end of last year, 2020.
Exactly. Yeah. But within this period, the COVID situation was still exacerbating. And so the question was that why would the government decide to hold, political meetings and gatherings and not even observe social distancing, among other things? So clearly, it speaks to larger volumes, and it leads us to the discussion around our built environment, because we must look at our built environment and social environment. If you look at the Ghanaian traditional architecture, it does not give room for social distancing, though it might give room to quarantine. So historically, quarantine is not alien to Ghanaians. When individuals are sick, the healer would be consulted, and he would rather, in his postulations, say that the one who is sick should be precluded from engaging in the economic activity, so that when he had recovered, he will get back to join the economic force and play his role to contribute to society. However, when this lockdown occurred, it was just something that was funny to those of us who understand Ghanaian physical built environment, because several compounds would host about 50 to 60 people. I'm telling you, a family, an average Ghanaian family size could be mother, father, children, could be around 7 to 10. And some of these people live in single rooms in the Ghanaian compounds. If you have all of these families not going to work, right, in the informal sector, and they are staying at home, what it means is that if anyone is already infected, the entire compound will be infected.
This is a very important point. Samuel, can I just, this is a very important point, because you see the lockdown policy, which was developed in documents from the WHO in comparison with China, was developed for a particular situation. But as you rightly say, in West Africa, firstly, most people spend a lot of their time outside. They are outside, they are going to market, they are working, they are trading, but they are not necessarily inside in their homes.
Right.
So the lockdown policy, in many ways, of forcing people to stay at home, stopping them from traveling, and making them stay within their the built environment, as you say, in some ways, is that actually a counterproductive policy for a society with a built environment and society like Ghana's?
Exactly. I mean, it was counterproductive, because what that meant in that respect is that apart from the disruption in terms of the economies of things, it also had a tendency or the proclivity to increase the spread of the pandemic. Initially, some of us did not even contemplate saying, but when we began to reflect, right, and begin to look at the question of our built environment, the fact that even within our built environment, you find sometimes only one toilet facility in a compound. Whereas in other European architecture, you might find maybe if you have 5 bedrooms in a house, you might have about 7 or 6 washrooms in there. In the Ghanaian setting, you might have about 50 or 60 people in a compound with only one toilet. What it means is that they will use public toilet, which is the KVIPs, known in Ghana as KVIPs. And so every morning you would see some levels of clusters, even at the KVIP. So the measure which ought to have been emphasized is the measure of social distancing and the measure of quarantining for those who have had some impact, some levels of impact, for example,
or some symptoms,
to stay at home, because we have overlooked the question. I mean, we have gone beyond the question, or we have refused to pay attention to Africa's social capital and Ghana's social capital. For example, we have suffered from malaria, which has been endemic in the region of sub-Saharan Africa and Ghana for that matter. And malaria remains the number one killer disease in our part of the world and continues to decimate lives beyond COVID-19. And so that the impact of malaria on the continent, and for that matter, sub-Saharan Africa and Ghana for that matter, it's really unparalleled. And you cannot compare COVID to that at all. If you look at Obiodun's introduction that he wrote to his special issue in his journal, you realize that he draws attention to the idea of malaria and the fact that Ghanaians and Africans have suffered from the scourge of malaria. And so that when we are having discussions around health impact and health outcomes and definition of what disease is and measuring disease impact and all that, we cannot make it a collective. I mean, we cannot come to a collective definition.
So, I mean, this is very important because, I mean, there are several things that are happening here. On the one hand, you are telling us that essentially the lockdown policy developed in in Europe and in China was not a policy designed for the social architecture of Ghana. And it was actually a policy which made things worse. And secondly, the economic impacts, which can be mitigated in some ways in some countries, in richer countries, could not be mitigated because of the enormous informal economy and informal sector in Ghana. And so the combined consequences of that must have been catastrophic, Samuel.
Exactly. So the only solution and way out was to have rather enforced social distancing and also enforce quarantining where individuals have shown symptoms. The third level, which resulted in this hastened policy, I mean, also lies within the WHO and public health discussions around the level of.
Let's talk about that for a minute, because I think this is very important as well. I mean, a lot of people in Britain and in America, I've seen people saying, that this was a sovereign decision taken by sovereign countries in Africa, and Ghana chose to make this, and of course that is the case. But on the other hand, was there not an enormous amount of political pressure coming from organizations like the WHO and donor countries? Do you think, how significant do you think that pressure was in taking this decision?
The WHO and its sister organization in West Africa, WAHO, played a role significantly, and Ghana Medical Association and the Ghana Health Service, right, definitely relied on the kind of regime that was put in place by the World Health Organization and its sister organization in West Africa. It is also important for us to appreciate the fact that they would be interested in that because they believe that it also comes with some potential benefits, if there be any, right, to support the kind of things in terms of finance and other things that will come to fighting the pandemic. So it's a shame that sometimes we overlook the indigenous capacity and also indigenous knowledge systems and approaches to want to face, questions around pandemic.
So essentially a top-down policy, from WHO is imposed rather than a community-led perspective.
Exactly. And for me, it's a critical question, so that when there is an imposition of same, we overlook the question of decentralization. And that's another broader question, because the Ghana Health Service itself is highly centralized. It is highly centralized. The powers are at the center. And so the periphery do not have capacity to take decision. It is based on the same centralization of power, which is coming from the WHO through WAHO to the the Ghana Health Service, that began to control the scheme of things. In spite of the fact that if we had looked at the local jurisdiction or territories, for example, if chiefs were given enormous power, and they are a kinsmen, right, were given some authority to engage in social action, to have broader social discourses and discussions, to allay fears, and to also look at possibly traditional and social strategies to support themselves in tandem with some of the supports that would have come with the signs of COVID, that would have given us enough, if you like, a better response than the way things were.
This is very interesting. You mentioned the Ebola epidemic in Sierra Leone, Liberia, and Guinea in 2014. And in fact, the lesson from that was precisely what you say, that actually dealing with the Ebola epidemic required community-led policies,
action, yes.
Community action. And as you will know, the WHO's own Alma Ata Declaration enshrines community-based healthcare as the principle of decision-making for public health. So in many ways, and many commentators are seeing the WHO's imposition of a policy like this, which is of course completely forgetting local contexts, as something which reverses that principle. I've compared it to, it would be as if when Ebola broke out in Sierra Leone, Liberia, and Guinea, all of Europe and America had to completely close their societies and economies.
Exactly.
Is that a fair comparison, would you say?
No, it's a fair comparison. That is why, for example, those who, for example, accuse the government of Ghana did say that the economy ought not to have shut down, the local economy. Rather, they ought to have closed our borders with a stringent kind of measure to make sure that the local population was protected. But beyond that, it leads us to the neocolonial construction of things. Because, to what extent would we overlook the discussion about the use of neem leaves and neem tree in Ghana? To what extent would we overlook the traditional approaches that people have used in this country till now to survive the scourge, if you like, if there is any? These things These things have been swept under the carpet. Toby, let me finish on that. Sorry about that. These things have been swept under the carpet. That African strategies, ways of boosting their immune system, ways of surviving this COVID have been swept under the carpet. And I propose that we need to begin to look for funding to look at the question around interest groups, issue definition, and the politics of traditional medicine around healthcare in Africa, and for that matter, within the space of COVID-19. Because it is always the case that the West and Europe, with its United Nations and WHO, are always interested in dictating the course of Africa, and what will happen to Africa is always drawn on their table, like they did in times of old when they shared Africa on paper before they took overseas.
Thank you, Samuel. I think this is very important, the requirement to understand the power and value of community-based and African-based health and the healthcare histories and traditions. Coming back to a point you made earlier, you were comparing COVID-19 to malaria. You said you couldn't compare them. And that brings us to the question of the impact of COVID as a disease in Ghana and in Africa. Now, many people say, as I'm sure you know, that the figures for mortalities are very underestimated on the African continent. And there are some studies which suggest that perhaps they are underestimated by maybe 200%. So they may be 3 times what the current figures suggest. What's your view on that? What are the fatalities in Ghana? How accurate do you think that is?
For example, confirmed cases in Ghana as at October 15th would have been around 129,592. Recoveries and discharge cases, as at 15th October would have been around 126,085. If you look at active cases now, we are looking at somewhere around the region of 2,338 plus. The death rate is around 1,169. The region where I sit, where my infections in Ashanti region, for example, is around 20,692. Now, in fact, the Ashanti region comes after Greater Accra region, and within, the timelines, it was around 70,007. Now, if you look at it from a population that is getting to about 40 million, and if you look at the level of impact, we have overlooked the question of cerebrospinal meningitis that began to increase in the northern region at the height of the COVID across the globe. People were dying of cerebrospinal meningitis in the northern and upper regions of Ghana than COVID-19. Malaria continued to kill people in Ghana than COVID-19. Indeed, NCDs, non-communicable diseases, are increasing in Ghana and causing a lot of death than COVID-19. The Africa's health fragility and research, I'm passionate about some of these things. And when I begin to go there, I sometimes get emotional and I begin to lose my thought along the lines. But I think that it's quite a shame, right? That we are not interested in first things first. We are always interested in what will give the West and the so-called puppet masters money to do what they do. If people have died, they have died because they are already underlying health conditions, like the NCDs are talking about.
Can I just interrupt there, Samuel? Is that the case? Because in Europe and in America, it is the case that there is this debate about underlying health conditions. Is it the case in Ghana also that those who have died
largely that is consistent in Ghana. Largely that has been the case. If you look at the trend of recoveries, it's higher than even hospitalization. In fact, if you want to even do, and it's difficult to do that comparison, influenza pandemic in way back an earlier period as compared to COVID-19. In terms of reportage, in terms of reporting and all that, yes, because of government effort to, test, trace, and treat, we got some numbers. But I can tell you with no shadow of turning or equivocation that there could be still some number of people who might have felt some symptoms, but never reported at the hospital, but never died.
And in terms of fatalities, you said there are 1,169. Do you think that's an accurate figure, or do you think it's quite a lot higher? What would you think about it?
So that's what I'm trying to say. What I'm trying to say is that these are reported cases, right? But beyond that, what I'm trying to establish is that the African and the Ghanaian, for that matter, has found several ways of surviving. Let me share with you some anecdotes. You know, and you know me because of where I write. I mean, I write a lot also on traditional medicine. And so I began to pay attention to some of these things when the COVID-19 came out. What Ghanaians began to pay attention to was two things: to live well and also to protect themselves. To live well meant that they began to look at food. And you need to look at the question of food history. Food history takes us to the question of eating for health and well-being. And so if you understand food history, and if you understand it from the African context and the Ghanaian context, the kind of food we eat here and the leaves that we use to prepare our meals are highly medicinal and are highly efficacious, among other things, to support, to treat, and also to boost the immunity or the immune system of Ghanaians. And so Ghanaians began to shy away from the fast food mentality, which they have imbibed from the West and elsewhere, to begin to look for traditional cuisines and African meals that really boost their immunity too. They began to go back to the days of old, where they would take their concoctions and decoctions in the morning, right before they stepped out to engage in the social activity. So, I mean, those days they would take a cupful of some concoction of, say, neem leaf, and drink it in the morning. And when they've returned from work, they will drink it in the evening. And I will share some anecdotes with you, including even medical doctors who will do this privately and will not talk about this in public. They will not talk about it in the public sphere of WHO, among other things. And what is significant within that, I mean, the thrust of my discussion is that Ghanaians have found ways of, I mean, building their physical resilience, however you want to put it, either in the construct of immunity or
so Ghanaians have, in a way, used their own food culture, their own health culture to ensure a strong immunity, and at the same time, there may have been fatalities, but those have mostly been people with underlying conditions.
Exactly, that is the point.
And probably, from what you're saying, the figures are not much higher than that. They may be somewhat higher, but not a huge amount.
No, they are not as high as the WHO and the other agencies would want to push.
So you actually think that the figures are in fact exaggerated?
Right, exactly. That's the point I'm trying to advance.
So the figures are exaggerated. Okay,
that's the point I'm trying to advance.
Because a lot of the people.
That's the point I'm trying to advance. Because you see, the question about medical errors will come up in the foreseeable future as we begin to peruse the laboratory results. We begin to look at the questions about testing and all that, right? Because there is a question of margin of error in even making a determination as to who has COVID and who has not. The question about medical errors, the question about laboratory, testing and shortfalls and all that. So we, even if you look at the science, we cannot say that the question of figures and data is accurate. We cannot do that.
So this is really important for our viewers and listeners, that in fact, although many people in the West have argued that the numbers of mortalities in Africa have been underestimated, you're actually saying they've been overestimated. So that's very important. And from what you're saying in this case, if nobody had tracked and traced, and if nobody had even known that COVID existed, in Ghana, people would not almost have noticed.
In Ghana, people would have found means of surviving, and also would have found means of, resuscitating themselves and moving on. Let me give you an example why I say that. Do you know how many ventilators do we have in this country? No. And some colleagues would want to read my articles, 2 articles on, the essence of science and technology in advancing healthcare in Ghana. You realize that we don't have these things as we talk about. And so there is no way we would be able to win the fight if it is only based on the science as WHO knows, or the science as the West knows. There is no way we would have come to where we are based on the science the Western society is aware of.
So it's an African. So it was African responses which really helped in Ghana.
Exactly, that is the point I'm trying to make. That is the point I'm trying to make.
But at the same time, of course, and I think this is a very important thing. And coming towards the end of our discussion, there are two questions I want to ask you about, Samuel. I mean, the first is that because of WHO, as we've been talking about, and its policy directive, in spite of the fact that, as you say, malaria and many other diseases are much more significant in Ghana than is COVID-19, the health policy focus has been on COVID-19. So the first question, what has been the impact of that on the treatment of other diseases? Has there been a negative impact on other vaccination programs, on other elements of healthcare because of the way in which healthcare has been directed at COVID-19 in Ghana?
Initially, we began to have that effect, if you like, if I'm permitted to put it that way, because we began to shy away from old questions around cerebrospinal meningitis. We began to shy away from old questions like malaria and increasing NCDs. That in itself is becoming worrying in this country and causing some increasing level of death in the past 20 years or so. And if you read the work of some writers like Amma, de Graaf, Akins, and the others, you realize that largely NCDs, for example, continues to increase and is killing a lot of, Ghanaians for that matter, and Africans. When the government began to look at this, the government was interested in also protecting health workers, provided some insurance and all that. And so at a point in time, everyone was going to a kind of space for some cover and protection. And so the attention was to find out whether anyone who reported at the hospital came with COVID, and that even if the symptoms were not so, they wanted to cross-check and all that. And so quite often the attention was shifted from these key areas, and that had the tendency or the proclivity to cause some mess-ups and also some increasing trend of death in that area. Having said that, I think Ghanaians began to talk about it. Myself, I said it on national TV, that we are talking about COVID. We are waiting for the West to get us vaccine for COVID. Where is vaccine for malaria? You see, in the 1930s, when Africans wanted to look at the science of our medicine, the pharmacopoeia of African herb, and the Nkrumah Aba from the western region of Ghana were interested in forming herbal associations and all that, Great Britain, your country, Toby, were not interested, but they were building school of tropical medicine in Europe and elsewhere to make sure that they would get their science right. And so largely, the COVID became a kind of charade for us, and it would have exacerbated our already underlying health predicament and challenges that we have survived around for years. And for me, fortune, was on our part, and fate really worked for us. If the West does not believe in that, we have believed in this for years. It is within this resilience that the African has survived against all odds. And I think that even in this space where we sit, the science does not tell us that COVID will decimate us. The science rather tells us that we must look at the question around NCD, the question around malaria, the question around CSM, and other related, epidemics or endemic diseases that have subsisted over time.
So this is very interesting. This is very interesting because you see in the West, the debate is around at the moment is about the lack of vaccines for COVID being donated or provided to African countries, and how this is causing a real problem in the pandemic. But from what you're saying, you would much rather have attention given to other health conditions than to COVID.
Toby, the question is that how many people have been vaccinated in Ghana? How many people?
I have no idea. You can tell me.
So the point I'm making is that it is kind of like dropping a sugar cube in the ocean, right? It's kind of would I say infinitesimal, right? It doesn't make sense, right? When we have to dance to, receive first consignment of COVID at our airport, dance to receive COVID vaccines. It's shameful.
Really,
right?
It's as you use the word charade. You would say the whole thing, this is all a bit of a charade, really, for you.
Right, because you see, the point is that How many people have been vaccinated in even organized institutions? How many people have been vaccinated? The question is that it is not the vaccine that will save us now. If there is any case to look at, let us look at Africa's existing health fragility. What it means is that let us look at the question of infrastructure. Look, Ghana has NHIS, National Health Insurance. You know, I also write extensively in that area. Yes. I've compared Rwanda and Ghana's case, right, when it comes to health insurance. Even though we have health insurance, there's still the question of accessibility to healthcare because of the question of proximity and all that. And maybe that is for another day. It's quite, shameful and disgusting, if I may, to suggest in any terms that some Western scholar or intellectual or expert or scientist, like what the UN wanted to do on us, another charade, to bring Matt Hancock to us too. It's the same narrative. It will not change. And Africa must get better.
So the fundamental thing is, if all this energy which is going into COVID vaccines was going into
infrastructure, technology, and all that
would make a much bigger difference to Africa, to Ghana.
Yes, than to wait for those things that are non-existent. Right.
Well, let's ask a final question then, Samuel. One of the impacts, of course, of the last 18 months has been because of all the measures which were taken in relatively poor countries such as Ghana, a huge amount of increased indebtedness had to be taken on. And also, of course, because the economy stopped, and there were big impacts on many economies in Africa, but of course also in Ghana, and increased. Now, there has been a lot of discussion about how the loans which were taken out in many countries are tied to future spending cuts and austerity from the IMF and other lending institutions. Is that the case in Ghana? And if that is the case, what do you think the impact of that will be on future health and infrastructural fragilities?
It's an interesting question. The government of Ghana, indeed looked at a COVID fund, right, to support this particular fight against the pandemic. The question is that the government has not been able to even account for say. There are a lot of struggle and push for salary increment. University teachers, went on strike and returned. Other other sectors, including teaching and other fields, have tried to even strike, right? Industrial action to make sure that they have some increment in terms of salaries and benefits and all that. But the question is that where is the money? The government went into this fight already gasping for air and looking for loans here and there. And so the COVID scare in itself led to panic, borrowing, panic spending, and all that to make sure that it will stop the effect of sin. Having said that, where we sit now, it's going to be difficult to say that we'll be able to recover in the shortest possible time. But what is important is that to which or what measurement are we saying that Africa's economy is in a quandary? Is it under the old charade of gross domestic product, balance of payment deficit, which you are an economic historian also, right? But you understand the question of accumulation of bullion and wealth and measurement and all that. For me, I still have a lot of questions around say. I think the fundamental question is that we should be interested in satisfying the fundamental bread and butter conditions, and secondly, scale up in building on Africa's infrastructure, and thirdly, be interested in dealing with the question of corruption and the kind of wrong synergy that some of our stakeholders have with the West to plunder our system.
Samuel, I wish I was with you in Kumasi, like one of the last times we met. But, it's been wonderful for you to share your insights with Collateral Global and our viewers and our listeners. And thank you very much indeed.
Thanks for having me. I'm grateful to be here.